Okay, good afternoon, ladies and gentlemen. My name is Jim Rutka. I'm chair of the Department of Surgery at the University of Toronto, and it gives me great pleasure today to have this opportunity to interview Dr. Charles Tator in the Division of Neurosurgery at the University of Toronto as part of this AANS Leaders in Neurosurgery fireside chat session. So, Charles, good afternoon. How are you?
Hi, Jim. I'm terrific. How are you doing?
Thank you. It's really great to see you. And given the pandemic and all that that's entailed, we haven't seen each other in person very often these past 2 years.
Exactly. It's been a shut-in couple of years for me, but I'm still having a good time.
Great. Well, Charles, I'm going to just ask some questions because you've had a phenomenal career in neurosurgery. And I know that the listeners on the line will want to know about how you made it to this point in your career. So what was your journey like to become a neurosurgeon, and why did you select for neurosurgery in the first place?
You know, I loved neuroanatomy in medical school. I really enjoyed learning about the brain in physiology, and it always turned me on. And in fact, I originally wanted to be a psychiatrist. But when I went on to the wards in psychiatry, it was amazing to me how little they knew about the brain. When I went into neurology after that, I was, feeling quite positive about becoming a neurologist. But then they, could make the diagnosis, but when it came to treatment, there was not much in those days that could be done. So you put the label on and that was about it. But when I had a little bit of time on neurosurgery, I thought, oh my goodness, that is for me, because, you can do something about what the patient is telling you and you can actually help people. And I guess it was, in my nature that I always got a kick out of helping people. And when I figured out that you could actually not only help people, but you could actually save someone's life. And so I did veer towards the life and death specialties, and neurosurgery was number one because of my fascination with the brain and the nervous system. And, it's been a great thing for me. I have really enjoyed neurosurgery. I love neurosurgery, in fact. I love the intricacies. And you may recall that one time I was specializing in acoustic neuromas. And when I think back to those days, like, why did I like that? It was so fascinating to see what the base of the skull looked like from inside somebody's head. And, when Bill Lougheed and Tom Morley and the great teachers that we had showed me the anatomy, like it was just an amazing thing. And I never got over that and wanted to be involved. So neurosurgery has been a joy to me all the way.
Well, that's great, Charles. So in addition to being an outstanding technical neurosurgeon, and you mentioned your skills in acoustic neuromal surgery, among many other types of surgery you did throughout your career, you became one of the first, for sure, in Canada and probably throughout North America, to be interested in research. And if I'm not mistaken, you started your career as a neuro-oncology researcher, and then you became a researcher in spinal cord injury. So maybe you could tell us about why you had this great interest and passion for research in neurosurgery and leading up to now what you're doing in spinal cord injury research.
Well, thank you for asking me to talk about that, because I often think back to what actually drove me into research, because all during medical school, it just didn't occur to me that I was going to spend a lot of time in laboratories and in dissection rooms and whatnot, figuring things out. I became fascinated by research early on in my training. So you may not know this, but I was actually selected by Harry Botterill. And then as soon as I was the last person that he invited to train in neurosurgery at the University of Toronto, because you had to be invited by him. In fact, you had to write a letter why you wanted to be a neurosurgeon. And he never forgot what I wrote in that letter, because about 20 years later, I met him at a social event, and he came up behind me and he whispered in my ear something that the only way he would have known that is because I wrote that in my letter. But it was so
Yeah.
amazing. But anyway, the day I showed up to start my training in neurosurgery, there was a collision of applicants. And so I was shunted off to the lab. And the lab that I was shunted off to was in neuropathology. Well, I had the greatest time of my life because I had a fantastic teacher, George Olszewski, who was a terrific scientist. And it was amazing to me. He opened up my eyes to the world of science, what you could do, just by measuring things, just by observing things, what was connected to what. It was very wonderful. And I never looked back after that. It was my entree into science. So I got I was supposed to stay for 1 year. 1 year became two, two became three, and I actually ended up with a PhD. And as you said, that was very unusual in those days. Maybe I was the first in the country to train in neurosurgery and do a PhD while I was there. And I really wanted others to have that experience. And so when I became chief at the University of Toronto, that was one of the things that I pushed, that I really wanted people to enjoy science. And I always felt that to enjoy science, you really had to put the effort into it. You had to spend a little bit of time in it. You had to learn, how to count, how to measure, how to do statistics so that you knew what you were measuring was accurate and meaningful. And so one of your predecessors, Professor Bernard Langer, was very instrumental in pushing me forward to put other people in the lab, in the scientific stream, in surgery. So you may recall that he chose Rudy Falk, Steve Strasberg, and myself to actually create the surgeon scientist program. That was one of the most enjoyable things I ever did. And when I think back to the people that, that were given that opportunity and enjoyed the opportunity and then spent the rest of their careers in combined science and practice, that was what I wanted to do. And yes, I did start in brain tumors, but I had another experience in my career when I encountered a surgeon who said he could create the best environment for the injured spinal cord by removing a vertebra and allowing the tension to be relieved at the injury site. And if the injury site needed to be removed, you could then oppose the two ends of the cord and things would grow across, he said, and you merely needed to shorten the spinal column in order to create the best environment for the spinal cord to recover. And of course, that was an idea that he had that was never proven. But he said he proved it, which was rather a sad event. But
Was
it
that Gordon
was,
Murray?
pardon me?
Was that Gordon Murray who?
That was Gordon Murray.
Okay.
And believe it or not, Jim, well, this is another experience, but at one time in my life, this was actually before I went into medical school. I had a little bit of doubt whether I wanted to be a doctor even. And so I spent time as an orderly, and I was assigned to the operating room at the Toronto General Hospital. And I saw the greatest surgeons in the world at that time operating, including Gordon Murray. He was the most beautiful surgeon to watch. And believe it or not, I attended one of the operations in which he was supposed to have sewn, the two ends of the spinal cord together. And of course, he didn't. And it was a sad event. But at any rate, the exposure of the spinal cord was absolutely fascinating to see what it looked like after 10 years of injury. Turned me on to trying to do something for spinal cord injury. And so, as you indicated, I switched. In fact, at one time I was conducting both neuro-oncology research and spinal cord injury research in the same laboratory. And somebody took me aside and said, Tator, pick one. You can't do two. And that was Tom Morley. And so at that time, I became more interested in trying to get the spinal cord to recover. So I picked spinal cord injury, and that's where I've been ever since, although I have had some other interests, like currently concussion is a big interest of mine.
Yeah, it's great, Charles. And maybe you could expound on why, or if it's still important to this day for neurosurgical trainees like residents or fellows to be involved in research, whether it's basic science, clinical health services. What would you say is your response to the importance of research amongst trainees in neurosurgery to this day?
Well, it's through research that gains are to be made. Like serendipity is important, inspiration is important, but like the great Sir Frederick Banting said, creativity is about 10% inspiration and 90% perspiration. And I think that is true. You have to put in the time to really be effective in research. And that's why my view was that you had to spend about 50% of your time in clinical practice to be any good, because we don't want to train people with dual careers who aren't good in both. And a dual career, like as a clinician scientist, isn't for everybody. But for those who want to do both, my view has always been they have to do 50-50 to put in sufficient time in each area to be effective. And to answer your question about why we need people who can do both, I think those people have a leg up in figuring out how to make gains, because the gains have to be on both levels. They have to be sort of practical enough to apply to a human being. So it can't be just something that's going to help an amoeba. It can't be something that makes the lamprey cord grow together, because at one time I was fascinated in why the lamprey could regrow its spinal cord and the human can't. And maybe if somebody unlocks that answer molecularly, we will have a better chance. But if you have a dual career, I think your antenna are better tuned to making gains. I think society is better off having some people like you, Jim, who has followed that idea that you can have a dual career. And I think that, maybe we're talking about 10% or 15% of active clinicians should have a big foot in research, but not just a pinky finger in research. Because I think we have to go toe to toe with people who are doing 100% research. And so if you can't speak their language, and if they don't have faith in your ideas because you're not trained enough, then it's not going to happen. The team won't be effective. And I think the days of being able to do it all yourself are gone. So you've got to do it as a team, and you won't be accepted as a true team member unless you can speak the language. And unless you put in the time as a scientist, you're not going to be able to speak the language.
Okay, well, thank you, Charles. Now, this next question is a tough one because throughout the course of your career, especially in science, you've had numerous contributions, especially in the field of spinal cord injury research. But what do you view as your most important contribution in this field?
Oh my goodness. Um, maybe it was my laboratory experience with early decompression of the spinal cord. I spent probably 20 years of my career examining the pathophysiology of acute spinal cord injury. And I really learned that incrementally because it was a time of explosion of technology. Like, for example, we learned what was going on using very sophisticated techniques like use of quantitative measurement of spinal cord blood flow in the rat. Like, imagine being able to measure the amount of blood flowing through the cord of a rat, which measures about 2.5 millimeters. And we could tell how much blood was flowing in about 100 micron squared piece of spinal cord tissue. And armed with that knowledge, it was apparent to me that trauma to the spinal cord caused fantastically rapid damage to the spinal cord, and that we couldn't wait for the patient to be brought, let's say, from up north from a mine cave-in, broke their back when the mine caved in, and then went to the local hospital, spent a day or two there, and then somebody said, well, we better transfer the patient to a center. That's the way it was when I started, and that had to change, and it did change. By we, I mean many people were involved in early trauma retrieval, not only resuscitation of the patient, but resuscitation of the nervous system, whether it was a brain injury or a spinal cord injury. Timing is so important because of the pathophysiological events are so rapid as we could exquisitely determine in the laboratory. Like we could tell when the glutamate went up and when it went down. And we could tell, when calcium entered nerve cells and knocked them off. And that made me want to speed things up clinically. And in fact, we did speed things up. We opened an acute spinal cord injury unit that never existed. And we advocated rapid transfer of patients and rapid decompression of the injured spinal cord. And that is still going on. And we're still not rapid enough, in my view. We still have a ways to go in getting people to the right center at the right time for the right condition and triage. And you see, there you go. That's a great example of why when you go to the lab, you see the guts of the problem. And then you try to translate that into action that is actually going to help people, that will move the pendulum to make it better for someone who does get a spinal cord injury. So I think that is why, maybe that's my most important contribution, maybe to accelerate the situation and to prove that early decompression, because we proved in the lab, both with monkeys, which you can't use nowadays with that type of experiment, and then in rats, we developed the first spinal cord injury small animal model and used that model. And it was amazing to see how similar the rat spinal cord is to the human spinal cord in terms of pathophysiology. And then when we developed the way to injure the rat spinal cord in a consistent fashion with graded injury and graded compression that we could remove at any time to simulate the decompression that a neurosurgeon would do in the operating room, and proved beyond a doubt that early decompression meant better recovery of function. And obviously, it was high up in the neck, better survival of the patient itself. Like one of the biggest thrills of my life was in managing a young woman who was about 18 at the time. Her name was Barbara Turnbull. The story is well known. And she was shot in the neck. And the bullet ended up between C3 and C4. And the first emergency medical personnel on the scene reported to me on the telephone, because I was on call that night, and that when he found her behind the counter in the milk store, he said she was breathing. They put her in the ambulance and she stopped breathing in the ambulance. They had to bag her all the way to the hospital. But when I spoke to him, he was resolute. She was breathing initially. And I said, you know what? I'm going to remove that bullet. And so we did. And that was within, I think we got it out within just 3 or 4 hours. It took her about a month on the ventilator in the ICU. And then she started breathing. That was a big thrill to me to see that happen. I'll never forget that story. I mean, and then she lived. She was 18. She lived until she was about 53. She became a reporter for the Toronto Star. She became an advocate for access for disabled people. She never recovered any limb movement, but she did recover her ability to breathe spontaneously, which Christopher Reeve, of course, who was injured at a similar level of the spinal cord, he never recovered complete respiratory independence and always had a portable respirator on the back of his wheelchair. But with Barbara Turnbull, she lived a very full life and ultimately died of another disease. And I became a very close friend of hers. And in fact, I became her general practitioner over the years. If she got a cold, she would call me.
So, yes, I'll just interject and say to the audience that there is at the University of Toronto a Tator Turnbull lectureship that was established in honor of you, Charles, of course, but also Barbara Turnbull, who had a phenomenal, successful career as a journalist, as you mentioned. And so those life stories are truly ones that move us and make us pursue those interests that you mentioned. In your case, continued work in the research lab. So I might ask you now, what motivates you to keep on going? And I'll say that because I'll tell the audience that you had a full career as a clinical neurosurgeon. You were the division head of neurosurgery at Sunnybrook Hospital. You then became the professor and chair of neurosurgery at the University of Toronto for a 10-year term. You continued all the while with your research work. You probably stepped down, Charles, from your practice in neurosurgery, I'm guessing about 15 years ago or so.
Yeah, that was about when I left the operating room. Yep.
And to this day, you're writing grants, you're working with advocacy groups, for more funding for both concussion and spinal cord injury groups. You're writing papers, you're graduating students. How do you do it? What keeps you motivated long into your career after being a clinical neurosurgeon?
I said I love neurosurgery, and the love affair has continued. I just find the field unbelievably important. As I said, it is a life and death specialty. You don't go into this specialty if you are timid. One of my best friends is a dermatologist, and he can't believe that I do what I do. It's not for everybody, but I find that I get the greatest satisfaction. Like, neurosurgery is nourishing me. It turns me on, and I don't want to give it up because I'm having too good a time. And as you said, I do like to do a bunch of things. I also like to teach. I really get turned on by teaching. And this morning I gave a lecture at 8 o'clock, and I'm giving another one at 6 o'clock. Can you believe that? 2 lectures today. And there is still, that attraction to me that I can tell somebody something that matters in the world. And I saw 6 patients yesterday in my office, and on the way out, one of them said to me, I really appreciate what you did. You were so, he said to me, you were so thorough. And he was so grateful that, that's what I don't want to give up. I mean, somebody tells me that I made a difference to them, like just one person in the office. Mm-hmm. To me, there's nothing more important than that.
Great, Charles. And you mentioned the difficulty, with some of the stresses in neurosurgery, as you said, not necessarily for everyone, given the demands, but not only that, the challenges that neurosurgeons face with life and death situations, not unusually. So what did you do throughout your career to maintain a semblance of balance, and what hobbies did you have? I see a fish on the wall behind you, and I know that you have a cottage. I don't know if you're a fisherman, but what was it that kept your sanity throughout these years, would you say?
I took very long holidays in the summer. I loved going to my cottage, which is in a remote area of the province. I love to do fishing there. I don't do fishing anymore because my daughter will not allow me to catch a fish. She is anti, doing anything harmful to any
Species,
moving species.
right?
So I'm not allowed to fish anymore. But the cottage is still an an unwinding, a chance to be in nature again. I just love that. It's tremendous unwinding. And the other reason I was able, and I think this is important, it was important to me, is my wife. My wife was an incredible soulmate, much smarter than I ever was, and extremely motivated, and also very kind, and also intense. In fact, this year was a very special year because she was awarded the Order of Canada. And as you know, I'm an Order of Canada, and you are too, Jim. So there are, it's what we do in this country. Canada has been a great place to live. And so here we are, two soulmates, me and my wife, Carol. We both have the Order of Canada, and we both still love each other. So that has actually been a tremendous reason why I've been able to have a good time. There's no question that without her support, and she was very definite about things. So, for example, when I would get an offer to think about moving somewhere else, she would say to me, "Oh, that's nice. You got another offer to go to X, Y, or Z university. That's fine. But keep one thing in mind. If you go alone." Because she loved Toronto, and she's a displaced Detroiter.
Yeah.
I snatched her from Detroit. We had a long distance love affair for many years before we married. And she said she's made her move and she's not moving again. So that was an important pillar in my life, and I think allowed me to do what I wanted to do. And she did what she wanted to do. And it was an amazing relationship.
Yeah, well, Carol is an amazing person, and I would agree with you. She's much smarter than you are. In fact, she's smarter than all of us, Charles, put together. So you definitely found the right person with whom to spend your life. So that's a very important point, I think, for the junior neurosurgeons to hear straight out on this conversation today. And Charles, my final question to you is, given how you've seen the world and particularly the field of neurosurgery change over the course of your career, now spanning well over 40, maybe 50 years, what advice would you give to young neurosurgeons starting out as you did when you started your training? What would you say to them to motivate them?
Well, I would say that you've chosen a career that is a very difficult one, but extremely rewarding. Like, you are so fortunate that you made that choice. The opportunities open to you are vast. You've been given an opportunity to help people who are desperately in need of help. You've been given the privilege of trying to heal somebody, and with that, without your input, that person won't be the same person. Like, it's an intense responsibility, but it's an amazing privilege. And I hope that you have as satisfying a career as I have had.
Okay, well, Charles, that's fantastic. It really was great getting caught up with you, as I said, because we haven't had a chance to speak together these past 2 years. And I'm delighted that this will be commemorated and also operationalized and memorialized in this series of AANS leaders in neurosurgery, which you truly are. So thank you very much for your participation today. And we really look forward to seeing you in person in the near future. Thank you, Charles.
Thank you, Jim. My pleasure to interact with you as always. Bye.